Well, good morning, everybody. Thank you for joining us for the November-December ERM Toolbox webinar. A couple of housekeeping notes before we get started. If you've dialed in by phone and haven't logged in by computer and you'd like to see the slides that will be shown during the webinar, please point your web browser to readytalk.com. In the box where it says Participant Join a Meeting, just enter the same access code that you used for the call, 987-9821. We have muted the phone lines, so no need to stay aware of the level of the background noise at the moment. If you have questions, you can type them into the chat box, which I will be monitoring and will relay to our presenter, or you can hold them to the end, at which point we will open the lines for Q&A. So as mentioned, there's the chat box. There's also, I believe, a raise hand button, which if you click on that, that will let me know that you have something to say, and I can unmute your line individually. Now, to introduce our presenter, Suzanne Holbach is a Vice President with the Marsh Global Healthcare Clinical Consulting Practice located in Atlanta, Georgia. She has experience in and is developing the service lines for the emergency department, ancillary services, urgent care centers, retail clinics, pre-hospital transport, cruise ships, interim management, and senior care. She joined Marsh Risk Consulting in 2011 and has over 28 years of experience in healthcare. Suzanne?
Well, thank you, Emily. I appreciate it. So thank you, everyone, for joining me today for an overview of the medical staff credentialing, privileging, and peer review in the ambulatory healthcare setting. Today we'll be talking about these objectives here, where we'll cover the difference between credentialing and privileging. We'll discuss some of the major findings that we find when we do assessments. We'll also describe some of the major components of credentialing and privileging as required by the American Association for Ambulatory Health Care, or AAAHC. And then we'll discuss why peer review and the integration of peer review is important in the credentialing or reappointment process. So to get started, first of all, credentialing and privileging are not interchangeable, although some organizations think they are. Credentialing is simply verifying the qualifications, the required education, the required training, the experience of a healthcare professional who does the hands-on care. Now, privileging is authorizing a professional to perform services at your healthcare center or at a particular location. And privileging is based on their clinical competence, based on their training or their licensure and their certifications. It's important to know that clinical privileges are specialty specific, but they're also based on a facility's capability to support that privilege, meaning, for example, you don't grant a provider a privilege for conscious sedation if your clinic doesn't do conscious sedation. There would be no need for that. So I hope that makes sense. What we typically find when we're asked to review a facility's credentialing and privileging process is the consistent need for staff education, the components that are necessary for a thorough process with credentialing and privileging. And then we also see that when there are systems out there, whether it's a system of hospitals or a hospitals and clinic system or clinics, that there is variation between the facilities from their sister facilities. So Clinic A may do some credentialing and privileging different than a sister hospital B, or sister clinic B, excuse me. Resource allocation is a common finding in that the person that does the credentialing, or persons, usually it's one person that does the credentialing and privileging, have a lot of other responsibilities or wear a lot of other hats. Now, what this means sometimes is, for those of you that do the credentialing and privileging out there, is that sometimes you're stretched pretty thin and people are on you to get other things done, and especially to move the credentialing and privileging process along, to hurry through that, to hurry the provider through that process so that you can get them up and working in the clinic. And it's a mistake to hurry through this process, and we'll talk a little bit more about why it's a mistake to hurry through the process. It really does need to be done correctly. And to do it correctly, unfortunately, it is time intensive, but as I'll talk about negligent credentialing a little bit further down in the presentation, why it is so important to take your time and to do this right. Now, peer review resources such as psychiatry may be a bit limited, but again, I'll get into the peer review later on this presentation and how it can support the credentialing and privileging process. Okay, credentialing again, this essentially means, just as a reminder, it's verifying the medical provider's professional history and qualifications. So the purpose of credentialing is just to make sure that providers you hire offer high quality care, safe care, that you minimize your liability exposure, and that you ensure that you're aware of any fraud, abuse, or sanctions against that provider, so that you're taking the necessary steps, as they say, your due diligence or your vetting process to make sure you know who you're hiring. And then also to ensure that that provider can meet the standard that your facility uses. Now the web page that I have posted on here is the OIG's Most Wanted Healthcare Fugitives. I don't know if any of you have seen this before, but it's actually a pretty interesting website. When I was reading it, there were more than 170 fugitives charged with related healthcare fraud and abuse. And that website actually gives you the names of the provider, their location, what they did wrong, if they were fined, if they were jailed. So it's pretty informative. There's also something out there called a National Practitioner Data Bank that clinics can actually register with to perform queries to view any malpractice claims history for a provider. And that, last time I checked, cost about $4.75 per query. So it's actually pretty cost effective and give you quite a bit of insight into the provider if they've had any kind of claims activity. Now credentialing requires primary source verification. And what that means is that you need to obtain the provider's credentials from the original or the primary source. So verification of their educational programs or the exams or any licenses that they hold. Like you would actually pick up the phone and call their medical school or their residency program to make sure that they really did go to that school and get the information directly from that source. It's going directly to the horse's mouth, so to speak. It's always nice when the provider provides you copies of their license, their certifications, their credentials, but it's nice, but it does not provide proof. The organization must also evaluate if any of the past history that a provider or an applicant has would disqualify them for a position or privileges being requested with your organization. Now secondary source verification differs in that you're not going to the horse's mouth or directly to the source to get the information that you need, but actually this is where you can obtain a verification report from like the AMA Physician Master Profile, who has a tremendous amount of information on physicians. Or you can go to the American Academy of Physician Assistants or the Dental Examiners or the Association of American Medical Colleges. There's a lot of different licensee boards or organizations where you can actually go to that site and you can get information from them. And it can be a printed report saying, yes, Dr. Smith was here and did this and this and this. Now, as I said, it's nice, and we've had it where we've had the providers give us copies of everything that we would need. But again, I can't stress this enough. While it's nice to have, you cannot accept that as proof of anything. So in delegation of credentialing, this is just simply when your organization allows or hires a service to perform the credentialing work. There are facilities out there that just don't have the time or the manpower to do the credentialing and privileging process because, as I stated earlier, this is a pretty time-intensive and probably labor-intensive, if you want to call it that, process. And the credentialing services, have to follow the rules and regs like everybody else. And it's important to know that if you hire someone to do this work, to know up front if they're going to delegate or subdelegate any of this work out. But regardless if they subdelegate any of that work out or if the organization you hire to do credentialing and privileging work, at the end of the day, you're buying their work, and that means you're responsible for that work. So if any time you're not comfortable with the quality of work that they've done or their approach to work or how they're doing the primary source or secondary source verification, you can reclaim that and end up doing it yourself. Or you can actually hire someone else out. And I'll talk a little bit more about these organizations a few slides down, about these credentialing verification organizations. Negligent credentialing, as I had mentioned a few slides ago, really plays a role in credentialing and privileging in that we all know that negligence is defined as it says here, the conduct that's culpable because it falls short of what a reasonable person would do to protect another individual from foreseeable risk or harm. Now, this can occur when an organization does not do proper credentialing or privileging and the patient ends up harmed. So as I had stated earlier, if you have someone that is rushing through this credentialing and privileging process, or if they have data that they can access to see how, if, for example, Dr. Smith is doing with his quality metrics, and they have the data but they're not taking that into account when they are doing credentialing and privileging, and something happens to a patient, your facility can be held liable in addition to the provider. It's kind of like being in charge of a department. You know, you may be in charge of the department and making sure that everybody is doing what they're supposed to be doing, but at the end of the day, if they hurt someone, they're going to come back to you, through an accident, an error, whatever. They're going to come back to you and go, well, okay, so how was this person trained? How do you know they have this certification or credential? Are they certified or credentialed? So that's why it's so important to ensure that you do not do shortcuts with credentialing and privileging, that it's thorough. You have to have someone very detail-oriented and very particular about doing things correctly each and every time. All a plaintiff attorney has to do to determine if an organization and a provider are negligent is they have to establish that the organization had a legal duty to select and retain competent practitioners, which that's pretty much what we're all charged with, is make sure we hire people that know what they're doing and they've got the education, training, and skills to do it, that the organization didn't meet the established standards of credentialing and privileging when granting that privileges to the practitioner, meaning, once again, what we probably all are aware of, we have these great policies and procedures in place on how to do different things, including credentialing and privileging, but we don't follow them. So we kind of shoot ourselves in the foot. They also can prove or have to prove that the practitioner was negligent while they were treating the patient and caused the injury while practicing under those particular privileges that you permitted, and that the negligent granting of those privileges caused or contributed to that plaintiff's injuries. So if you do everything correctly with credentialing and privileging and do your due diligence through your primary source verification and your secondary source, and you follow your policy, you dot your I's, you cross your T's, and the provider still ends up, for example, hurting someone, as long as you've done everything correctly, you minimize your liability exposure. But again, you're going to have to be able to prove that, because we all know in a court of law, if it's not documented, it hasn't been done, so you got to prove it. The credentialing issues in the ambulatory setting, what we see is that consistent credentialing process is not followed, or there's no evidence or indication that the governing body is actively involved to approve or decline a provider's application or reapplication. That we see quite a bit. And additionally, we also see where the peer review process and or any quality data markers are not used in the credentialing decisions. And as I had indicated in the prior slide discussing negligent credentialing, if you have that data and you're not using that data, there's going to be a problem, because that data, while everyone can like Dr. Smith and patients can like Dr. Smith, and he's been with us a long time and he's such a good guy and so sweet, or her, okay. But when you look at their data, it may say something differently. The case in point is a lot of the providers are working very hard. They work long hours. They want to see as many patients as they can. They want to do the right thing by the patient. But sometimes at the end of the day, you have so much energy and you can't keep up and you kind of struggle a little bit. And so, you may not be current with the most updated standards. And if you're not and end up hurting a patient, that's one of the things they're going to bring up. So that's why that's important. Now, with the Accreditation Association for Ambulatory Health Care, or the AAAHC, they have a 3-phase credentialing process, as it's outlined here. They want you to establish minimum training and experience or other requirements like credentials for physicians. They want you to be able to create a process so that you can review and assess and validate an individual's qualifications, and that includes education, training, and experience, and licensure, and all of that. And then they want you to be able to carry out a review and assess and validate as you've outlined in your policy. So you have to first establish what you want out of a provider for your particular clinic or organization, and then create that process to make sure that you're sticking with what you've established for minimum training and education and experience. And then how often are you going to review it, and what are you going to review? Now, the role of the governing body that they play into the credentialing process, they actually, as I had alluded to in a few slides before, is they have to be actively involved in this entire process. And that also means that the medical staff must be accountable to them. Medical staff usually will listen to the governing body because of who they are and the amount of power that they wield. But again, the governing body needs to be involved and establish the credentialing and reappointment processes uniformly. It can't work one way for certain physicians and another way for someone else. It has to be blinded, so to speak. They have to apply all of those requirements across the board the same. The governing body also must be willing, and this one it can be a little bit tough in organizations I've been in. The governing body has to be willing to suspend or revoke clinical privileges. And this is a hard thing for a lot of governing bodies to do. But if it's necessary, if the situation warrants it, they have to be able to do that. And on the flip side of that, when it gets to this point, there also have to be processes or policies or steps in place for the appeal process. And again, the governing body, as I've probably said about 4 times already, has to be involved in the credentialing and review process. But when they are involved in that credentialing and privileging review process, they need access to that data, to the peer review data, to the quality data, so that they can make that decision whether to appoint or reappoint. Now, according to the AAHC, it's okay, it's permissible for a clinic, for a hospital, for an organization to use a CVO for a credentialing process. CVO is Credentials Verification Organization. And as you can see here, CVOs can actually become nationally certified. So for example, what I have here is MedVersant is certified by both the National Committee on Quality Assurance, and then they're also certified with the Utilization Review Accreditation Commission. And that it's like getting Joint Commission accredited or DNV or IMQ. It just means that they have met a standard. And that's important because at least that's the baseline. You know that they meet at least this minimum standard. Okay. Oops. Okay, there we go. Sorry, I hit the wrong button here for a second. Now, critical care credentialing, this may seem a bit off subject, but I was asked to add a few slides about critical care credentialing, so someone must have requested it from your organization. So I've got a few slides in here, and it's actually a good FYI because there's a lot of questions that come around this topic, and just kind of put it in your brain as just additional information, file it back there should you ever need it. The questions that come up is, should critical care credentialing be differentiated from other specialties? Should they be set apart? Is everyone in critical care expected to have the same skill set? Do they need the same credentials? Should the capabilities and expectations of one ICU differ from another ICU? And what does critical care credentialing exactly look like? Are there core privileges that every critical care provider must have, since they all come from different backgrounds and training? These are some of the questions that as an organization that has in critical care needs to be able to answer. And then how are you going to assess their clinical competence? Well, again, you go back to training and education. What medical school did they go to? What residency or fellowship did they go to? What continuing medical education are they doing? If they're board certified in their specialty, are they maintaining that certification? You can also go to the Department of Public Health and you can check out their publicly reported outcomes as well. And in this day and age with the Internet, it is so easy now to go ahead and pull up information on providers and their quality metrics that it just gets easier and easier to be more well informed about who you're hiring. The Zaggett's Guide.
Oh, no, I'm sorry. I thought you were done with the slide.
That's okay.
So let me know when you have a moment. We have a couple of questions in the chat box.
Okay, let me just finish this slide. The Zaggett's Guide to Critical Care Medicine is just simply a way to collect and correlate or rate a physician's data such as ventilator-associated pneumonia, central line infection, length of stay, quality of life. So it's just an approach on how to assess or rate a physician. Okay.
Great. So a question from the chat box. Regarding the credentialing of other caregivers, to what extent are phlebotomists, medical assistants, pharmacy technicians, etc., sent through a credentialing process that includes primary source verification?
That's a good question. Again, you go back to first of all, what does that will vary from facility to facility. So clinic to clinic, hospital to hospital. It depends on what your standards are. I have seen where, depending on the list of different specialties there that you gave, like lab, where did they go? Where did they go to school? How were they trained? I've been to a number of facilities where the facility actually has their own training on how they want labs to be drawn. So I would tell you to if you don't have a policy on how you want to do it, develop one. If you do have a policy, to reevaluate that. And actually, if you belong to a system of clinics or clinic-hospital combination, you may want to see how they're doing it. Because what's important, and I'll mention probably further down the line if I haven't already mentioned it, is that it's a good idea to be consistent when you are credentialing or privileging someone to work in your facility. And the reason that is when you have variation, that's when mistakes get made. So if you're consistent in your approach on how to ensure someone has the right training and competency, then across the board you need to do it consistently so that you don't miss anything.
Great. And then one more question. If the CVO does not fulfill its duties in conducting the primary source verification, should the client notify the CVO's accrediting organization?
Oh, that's a good question. The first step that I actually would take is talk to the CVO, their manager, director, or whoever your point of contact is there. Because if they're not doing a good job, then I would absolutely notify that person in charge there. It's always good to talk to them first, but I would have no compunction about contacting their accrediting body. And you can, just like anybody else, you can lodge a complaint. Okay?
That's it.
Okay, all right. All right. So then the next slide. Okay. The credentials and compliance. Credentialing helps to determine competence of your providers. It helps to determine. But it's important to understand that credentials may not be the same for all providers. As I discussed earlier, sometimes they have different training and education. There's no really one-size-fits-all. You can have some critical care providers with varying skill sets. So just to catch up, we're still talking about critical care credentialing. Okay. Again, as I stated, while credentials help to determine competence level of your providers, the specific privileges will vary from provider to provider. And this is where, again, I mean, you're going to get tired of me saying this, this is where quality outcomes are important. Meaning, for example, if I have a privilege of inserting chest tubes, or let's just say doing suture repair, but yet I have a high infection or complication rate, that should show up in my quality outcomes or quality report. And someone should be looking at that and catching that. For example, out of 10 people that I either sutured up or put a chest tube in, 7 of them or 5 of them had infections and had to be put on antibiotics. Well, that should be raising a red flag to somebody. so what this should do, it means when that red flag is raised, there's an investigation of some sort, and that means I get some kind of remedial training, or I can no longer maintain that privilege. And that pretty much goes not even just with critical care, with anything across the board, in any healthcare setting. When you're tracking these quality metrics, that you really look at them and figure out where your threshold is, where your benchmark is. Out of 10 patients, is it okay to have 1 infection out of 10? Well, maybe it depends on the procedure. These here are just the Joint Commission's 6 core competencies for critical care, and they can be found on their website. And I'm not going to go into great detail in them because I know you're not here to listen about critical care competency. But just so that you know, if you're interested, you can actually go to the Joint Commission website and you can pull up quite a bit of information on what is under each one of these headers, what Joint Commission expects for core competencies. That information is out there, and I believe it's free. Okay, so let's swing back to a few credentialing tips. Some of these may seem obvious, but as I had stated earlier, if you don't have a consistent methodical process in your approach to credentialing and to privileging, sometimes these things can fall by the wayside, get forgotten, you can get interrupted, you can feel a lot of pressure to get it done, and so you forget sometimes to do the most obvious. And again, the talking to other providers, the doctor-to-doctor contact with references is always a great idea. Read between the lines with the application and the information provided. Ask questions about any gaps you don't quite understand, because all this information that's sent to you or that you're reading and reviewing should actually paint a picture about that provider and should just kind of paint a story of their professional history. And as I said before, don't rush the application. I know there are some of you out there that you're the Lone Ranger out there doing the credentialing and privileging in addition to probably 50 other things, and the tendency could be to rush through it. But again, when we talked about negligent credentialing, that can come back and bite you or the organization in the butt a little bit. And again, you have to remember that when you're doing this process, the credentialing and privileging process, the patient's the end user, meaning you want them to have a positive experience with that provider. And then you also want them to walk away with a positive frame of reference about your organization. So if you kind of cut corners on the credentialing and privileging process, you could actually be putting your reputation as an organization at risk. It's important also to interview the applicants. I know that applicants move from state to state, and sometimes the tendency is, well, I've talked to them on the phone, it's all good. You can do Skype now to interview people. That has worked very, very well if they can't fly out and you can't meet them face to face. And again, don't automatically reappoint Dr. Smith because he or she has been there, everybody likes them, without first looking at their data. It's great that they're well liked, patients like them, you like them, they're easy to work with, they're nice people. But at the end of the day, if something happens and you've reappointed them without looking at the quality data, and the quality data shows that there should be opportunity for improvement in laceration repair or in a closed reduction or whatever service line that you provide in your clinic, it could come home to haunt you a little bit. So again, don't cut corners. Take a look at that data. Data. Privileging. So privileging is just really the process where the healthcare practitioner or provider is granted authority to provide certain care and services or procedures and treatments to patients within your facility. That's what that is. You're allowing them to do a specific set of things or stuff for a patient. I know that's not very medical, but that's essentially what it is. So again, this should look probably a little bit familiar to you because again, the AAHC has a 3-phase process for privileging, similar to what they have had for credentialing. They won't, a little bit different, but still a 3-phase process. For privileging, you must determine what clinical procedures or treatments that patients can be offered, and you must know what qualifications are needed for each privilege, and then have an ongoing way to evaluate the provider going forward, as to whether they can continue to provide that procedure or if there are modifications or a complete denial to perform that procedure. Again, I go back to laceration repair. If a lot of my patients are coming out infected, then again, you need to do an investigation. Maybe I can't do lac repairs. Maybe, who knows why those patients are getting infected. But if you can't determine the reason, then maybe I may need some kind of supervision or a total revoking of my ability to perform that procedure. Now, the privileging process could involve any combination of the following here. You can use primary source verification, to prove that the provider passed that certification or that training, or a supervising clinician with a particular skill set could do a direct review for a provider, or actually a direct proctoring can occur where you're actually training someone and watching someone do a specific procedure. Whatever the procedure or treatment that is privileged should be appropriate for your clinic and the provider, meaning that it wouldn't be appropriate to privilege a podiatrist to perform some kind of eye procedure. I kind of refer to it as going out on the football field playing basketball with a baseball. It just kind of has to connect, and it has to be relevant. Core privileging is just pretty much your basic training and competency needed for a particular specialty. So for podiatrists or internal medicine docs or your primary care physicians, they usually have a core set of training and competency under their belt. And that's all that means. It's just your core set of skills. Now, privileging issues that pop out with some regularity are when privileges are bridged from one facility to another without really defining what those privileges should be at a particular site. Privileges should be site-specific, not only to ensure that the provider is competent to perform that treatment or procedure, but also to ensure that the clinic or facility can support that particular privilege. Privileging is a very fluid process, and it takes place over time, and it requires reevaluation and updating on a regular basis because clinicians' practice or roles can change and expand. But it seems like every day, the world is moving so fast and healthcare is changing so quickly that what you're doing today, it may evolve into something else tomorrow. So this evaluation process, though, again, we're going back to data, and you're probably tired of hearing that, but this evaluation process really does require a quality assurance program, again, data, that can produce clinically relevant information to serve as like a minimum benchmark. Again, governing body must be involved to outline what privileges are appropriate and need to be documented and recorded. So again, in the credentialing and privileging process and in the peer review process that we'll talk about shortly, your governing body has to be actively involved in all of this. And I say that because I've been to a number of institutions where the governing body, it does not appear, at least through documentation, that they're actively involved in the entire process, whether it's appointing, reappointing, or the peer review process. So governing body, it's incredibly important that they be involved. So since I've harped on peer review quite a bit, let's talk about how peer review plays into credentialing and privileging. So peer review in AAAHC, the AAHC requires that a facility or organization have an active, organized peer review process. And I got to stop right there and just sit on the two words active and organized, because again, I've worked in a lot of facilities, and I've been to a number of facilities where they can have a beautiful peer review process on paper, but they don't follow their peer review process on paper, meaning that there can be peer review data submitted to the peer review committee, and nothing is done with it. It's ineffective. It's not active. Because sometimes, depending on the culture of your organization, physicians sometimes have a hard time doing this type of review. And so that's why it's important to find physicians that are interested in this peer review process so they can actually make physicians and your practice that much better. And that's really what it's about. It's not to beat someone over the head mercilessly and go, you're terrible, you're awful. It's a way of going, hey, there's an issue here, let's address it. Let's lay it on the table and let's address it. Now, having said that, the peer review process should be integrated with that quality program, which of course is collecting all of your data, trending and tracking your provider's performance. And again, as I probably said about 3 times already, the governing body must be involved and have oversight of all of this. When a peer review process is done on a physician, 2 physicians must be involved in the peer review process. And if you have a mid-level provider like a nurse practitioner or a physician's assistant, you still need the 2 professionals, but one of those folks needs to be a physician. And it's important to note here that all healthcare professionals should be involved in the criteria that evaluate their performance. It's just like any performance evaluation. It can stay the same for a couple of years in a row, and then as I had mentioned previously, healthcare is evolving so quickly that the roles are changing and expanding. So when you're going through a peer review process, you have to make sure that the criteria is applicable to what you're currently doing so that it really is a valid process. Okay. Peer review actually, I hope I didn't get ahead of myself here. Peer review actually examines the work of peer review through, like I said, continual data review and helps determine if that physician under review is actually meeting the acceptable standards in rendering any kind of medical services. And this information, again, needs to be reported to the governing body. So the theme here should be that governing body, again, has to be actively involved in all of this and used to help determine privileges. Now, to help support healthcare, let me see if I got behind here or not. Oh, no, I didn't. Okay. So to help support healthcare professionals, an organization should have current literature and research and education and policies and procedures that actually reflect that they're actually helping providers maintain and participate in continuing education. And you need the documentation also to support that. One of the hospitals I actually had worked at, one way that we actually did this was we would request that a physician once a month, actually once a week, we had physicians at lunchtime present some kind of continuing education for the entire hospital and for clinics. And what happened there was they all took turns in doing that, and that means that whoever is presenting has to do the homework on updating people on what's happening with anything out there, whether it be coding, billing, care, it doesn't matter. But it's just they get to pick the topic and then they get to share that information with folks. It's kind of like a lunch and learn that probably many people have done. But it's actually a good way to keep people current, to keep them engaged in that continuing education process. Now, it's also important that as an organization, as a clinic, that you have a way to continually monitor licenses or certifications that are going to expire. I've worked with a lot of docs, and you probably have as well, that's one of the few things they think about until they get a notice from somebody going, hey, my license, my certification, oh crap, it expires in 3 months. I got to get on this. And then they're struggling to find, whatever class or education they need to make sure that they don't expire. So it's really quite helpful if you have a system in place that gives them reminders about when things are getting set to expire. Peer review activities are actually protected from discovery by the California Evidence Code 1157. That's a good thing, because peer review really is about identifying issues, laying it on the table, and figuring out what approach you need to take to address the issue. The meetings are usually closed, so it's not open to everybody, and they are supposed to be unbiased and anonymous and objective. And if there is an issue, remediation should be the primary focus, and discipline coming in second. And if you have a practitioner, for example, that is intentionally violating a care pathway that you have in place at your clinic, or a procedure, refuses to do the procedure your way, the way that your clinic outlined it, then that's an entirely different story when they intentionally refuse to follow your clinic's protocol. That's the time, unfortunately, that you have to get HR involved. But usually before then, you know what the issue is with the practitioner if you've got physicians that are, or actually staff involved in reporting physicians or providers to peer review. Hopefully it doesn't get that far because you're on it. And in usually a clinic setting, unless you're a very, very large clinic, you know each other pretty well, and you know the strengths and weaknesses of all your colleagues. Excuse me. There are a lot of, oh, I'm sorry.
Now is a good time for it. We have a question.
Yes.
Let me just unmute that line. Katie?
Yes, it's Katie Pickard. I just wanted to, you mentioned that privileging is a very fluid process because people can be issued new privileges and not necessarily go through another review. And how have you seen that work at various clinics in order to have some sort of control over the process?
Well, if there's, for example, if in your clinic when let's say there's a new piece of equipment that's coming out, your clinic has purchased a new piece of equipment, that's a time where, and that's an easy one because it's like, okay, everybody, we've got this new piece of equipment, and equipment, and everyone needs to be familiar with it. So whatever your approach is to educating, checking people off on that equipment or that procedure, that's when you you have to set a specific time aside to make sure that education, information, a check off, again, whatever it is provided and that everybody gets done. So, that's a simpler one that I've seen. Did you have a specific question or a specific example in mind, perhaps?
No, I just was thinking, if it's very fluid, most people can set up a reminder for quarterly or annual or semi-annual review, but if it's fluid, it's very difficult then to get a handle on it.
It can be, and so, I guess it goes back to, those quarterly reminders tonight, but whenever you have any kind of change, that should signal, ding, 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 that we've got to, if there's a change in a procedure, for example, or let's say, here's one. Let's say your clinic hasn't done conscious sedation. I've seen this before, where you haven't done conscious sedation. And in order to do conscious sedation, you have to have certain policies in place, and there's a staffing expectation and vital signs to be monitored, and who can, give the conscious sedation, and who needs to be on hand, and what life-saving equipment you need. That's where you pull out all the stops, and you absolutely know, because again, this is a change in your typical service line or what you typically do at your clinics. This is where you pull out all the stops and go, everyone has to be a credentialed or privileged on this. So everyone has to know. So that's one of the examples that come to mind. But when it is that fluid, sometimes I can see where, especially if you have subtle changes to, let's say, a procedure or to a policy, it can kind of slip under the wire and you can forget about it and not think about it. I know that I've actually experienced this myself where I was in charge of a department and we had some subtle policy changes, not really big deal policy changes. And sometimes to get the staff together to remind them or to tell them, inform them about it, you just didn't want to put out a memo because that's not good enough. I'd actually put together a little packet and then put a face sheet on the outside of it saying, outlining what the change was, and with the policy attached, and then what they had to do was sign and date that they are responsible for that information and that they dated and understand it, and they had to turn it into me, and then I would track that. So that actually helped keep me out of the fire a few times, and that's for those subtle changes.
Thank you very much.
You're welcome. Okay, so we'll talk about ways to trigger a peer review process. I know, again, you guys are going to roll your eyes, but when I talk about quality and data, when you're looking at quality and data and you see, let's just say, an indication or a trend that a provider seems to be having more difficulty than other providers, that's when you can trigger the peer review process through your routine quality screen. You go, oh, Dr. Smith seems to be having an issue with his infections whenever he does a laceration repair. That's how you can trigger a peer review process. Let's find out what's going on here. a complaint, can trigger a peer review process, an unusual event, a sentinel event, or actually anyone can issue can refer an issue for peer review. For example, physicians that are abusive or disruptive. Now, most facilities, clinics, hospitals, any healthcare setting, what I usually see, but still not all the time, is there is a policy in place for disruptive physicians. Now, what's interesting is sometimes they will tack that right onto sexual harassment policy, which isn't quite the same. And so you need to have your own standalone. But what I have experienced and have seen in a lot of other facilities is that you can fill out the peer review form and send the complaint to the peer review committee where they need to address it. Now, the only downside to that is that you don't always know if it's been addressed. You don't get an answer. You have to take it on faith, I guess, that the peer review process is active, it's organized, it's fully functional, and that when things are submitted to peer review that they actually are taken care of. And that's usually one of the complaints that I hear. I don't know if you hear it out there, but they'll go, well, I sent it to peer review and I don't know what happened. Well, you're not going to know what happened. You're just not. But the thing that you have to do, and what I've always stressed to anyone that I've ever supervised, is your part is to report the issue. And then you have to just let it up to the system, because at some point in time, the last thing I want to hear from anyone that's in the peer review committee or the quality committee is, we're never told anything like that. That was never reported. You're like, So people have to do their part. If there's an issue, a concern, then it needs to be the form filled out and sent forward. And again, you have to rely a little bit on faith that you have an active, organized peer review. Okay. Now the possible outcomes here for peer review, which I'm sure many of you have probably experienced, no action, which I think most people think, well, there is no action, or education may be needed. Maybe one of the findings out of peer review, they may say that that particular provider may need to be monitored for a certain procedure or treatment that they're doing. Or there may be something as severe as suspension or termination, again, depending on what happens in peer review. Now, this next slide is just the visual of a peer review process, and it comes from the Comprehensive Study of Peer Review in California. And again, the top part of it is the indicators that can trigger peer review, and then the bottom are the outcomes. And you can see that even there's behavior counseling, change in privileges, monitoring or proctoring, education, training, no action, suspension or termination. So there's a lot of things that can happen out of peer review. You may not always be aware. You may be aware of it way after the fact when Dr. Smith is no longer there. So that's just a visual for you guys. Now, as of January 1st of 2011, when a peer review has been triggered and a decision has been made as required by 805.01 of the California Business and Professionals Code, a peer review form must be completed after the investigation is done. Now, I've listed here the 4 reasons that this form is completed. I think we're probably all pretty familiar with this, but this is incompetence or gross deviation from a standard of care which involved a death or serious harm or injury to a patient, the use of prescription or administering to himself or herself any controlled substance to the extent that it impairs your ability to safely practice. Repeated acts of clearly excessive prescribing, furnishing, or administering controlled substances. And there was a great example of this that I was actually aware when I lived in Northern California of a physician. He was called the pain doctor. I'll leave his name out of it, but he would write prescriptions for his patients for narcotics, and then he would send them to a particular pharmacy where they would, without question, fill that prescription. Needless to say, it made the papers and, of course, gave them all kinds of attention, where actually he went to jail, and I believe the owners of the pharmacy went to jail as well. So, it's one of those things that actually is being monitored out there, so you have to be careful how you prescribe. And there's databases out there now, especially if if there's frequent flyers that come into your clinic asking for, medication, certain kind of controlled substance, where you can actually put that into a database, and physicians, before they prescribe anything, can actually check that database to see if patient A this is the 7th time that he's been into a clinic this week and asking for Vicodin. And the last one is sexual misconduct, with one or more patients during the course of a treatment or during an examination. Now, the interesting thing is that this information is kept confidential, and it is not subject to discovery, except that it can be reviewed during a disciplinary hearing. So it's very controlled. Typically, again, kept confidential, but only under certain circumstances is it viewed. It's not publicly reported information, which is probably not a bad thing. Now, this website that I have attached will give you a little bit more information about what this really looks like if you're interested. Wow, okay, we're already to the end here. In this day and age, any and all healthcare facilities, I don't care if you're a clinic, if you're a hospital, if you're a nursing home, if you're a rehab, if you're psych, everyone seems to be looking at healthcare under the microscope, and everyone's being investigated and probed, and the questions being asked, well, how do you know you're giving quality care? How are you providing it? What are you doing? How do you know the providers that you're hiring actually can do what they say they can do? What's your process for checking that out? Well, and that's where I go back to, if you have a solid, valid credentialing and privileging process with an active peer review, because again, you get to look at data. It's a crucial step in providing that care. And I think at the end of the day, everyone here on the phone, and actually healthcare providers want to take good care of their patients. They want to have the time to do great quality care. And I really think that's where everyone's heart is at. But again, there are a few stinkers out there, and it is our responsibility to our patients and to our organization to ensure that the credentialing and privileging process is very thorough and that no shortcuts are taken. And with that, I'll let you guys off the hook.
All right. I will go ahead and unmute the line, so if people have questions.
The conference has been unmuted.
I can let you have
lines are open. Feel free to ask them.
Because I want to always have a after dinner to show up.
And I think although we're getting a little background noise, I don't think that was a question.
Yeah, I couldn't quite hear it.
Okay, it sounds like we don't have any questions.
All right.
If anyone does have a question, please feel free to email us. If you send me an email, and I will be happy to relay it to Suzanne.
Thank you.
And we hope to see you at Toolbox webinars in 2014.
Thank you, Suzanne.
You're welcome. Thank you.
Thanks for joining us, everybody.
Thank you. Please stand by.